Well, again, welcome to your CPG upskilling for 2021. This particular session is on sepsis. There is a couple of new sepsis CPGs, one for adults and one for kiddies. So we're just going to do a bit of a recap on sepsis itself and have a brief look at the actual CPG. Also, I have a couple of videos embedded in here which we can have a look at, which hopefully should visually maybe open up your knowledge a little bit more than what it is already. Sepsis. So this upskilling session is going to have a look at sepsis itself. We're going to revise it. So the knowledge of sepsis, severe sepsis, also known as hypoperfusion, because tissue is not being perfused, and we get tissue death. Infection. We're going to look at sepsis and SURS criteria. We're going to have a look at what they call severe sepsis and septic shock, and we're going to look at the actual CPGs itself. Okay. So infection or sepsis, well, what is the difference? So an infection versus sepsis. So an infection can actually become sepsis. Infections are common in life as we become exposed to everything basically. We've got bacteria, viruses and fungi, which are the common things which get inside us and infect us and cause issue. The body's immune system fights infection and keeps us healthy. Contrary to popular belief, our immune system keeps us safe in this world. It builds up a database as we grow in this world. So as young children, we get exposed to a lot of pathogens, be they bacterial, viral or fungal, and we build up a database to these things of white cells. Our immune system itself then, when we come in contact with these pathogens again, allows us to fight them and to kill them and to get rid of them. However, sometimes we can have, as part of the immune response, we have the inflammatory response, and we have pro-inflammatory stuff that makes all our inflammation run, and stuff that balances it off and takes our inflammatory processes away, and they have to be in balance. If we get it that it's out of balance and the inflammatory response becomes really, really big, this can develop into sepsis. So we're going to have a chat about it. The body's immune system fights infection and keeps us healthy. When the body develops an overreactive response to an infection, this can develop into sepsis itself. So systemic responses to infections are easily observed with primary, secondary survey, patient history, and a set of vital signs. And if we do these things always, it will always lead us to what's going on. So patient history, a set of vital signs, and a primary and secondary survey will lead us where we need to go. Origins of common infections. So common infections that we see, respiratory infections, urinary tract infections, infections in the skin like cellulitis, intra-abdominal infections, meningitis, inflammation within the meninges in the central nervous system. These are common infections. The most common of these, probably the likes of your urinary tract, your respiratory, and your intra-abdominal, which would be your gastric infections. Very common. Early signs of infection. So a fever greater than 38.3 or less than 36. So fever is 1. Again, temperature rises or will drop, and this is a big indicator of infection. What else? Tachycardia, so age-appropriate heart rates. So tachycardia being a fast heart rate. So if you're a pediatric, and you're running rates of 60, 70, 80 beats per minute, yeah, okay. But some really, really young children may have fast heartbeats. Small children can have heart rates which are normal for them of 100, 120. Newborns, heart rates of 140, 150 are common. Adults, in general, rates over 90 to 100 would be considered tachycardia. Elevated respiratory rates, so again, we'll talk about adult values, so 20 plus per minute, somebody's working hard to get gas exchange. So, tachypnea, tachypnea, elevated breathing with elevated respiration rates which are age appropriate for adults and kids. Non-blanching rashes in children may be a sign of meningitis. An infection, a common in kiddies, origin of infection, which leads to sepsis. Coughs, respiratory tract infections. Dark, foul-smelling urine may be indicative of urinary tract infections, particularly in the elderly. And vomiting or diarrhea are a big indicator of abdominal infections or infections within the gastric tract itself. So what's sepsis? So sepsis is actually the body's response to infection. So if we have too much of a response, it'll become septic. If we have too little, we will get a serious infection and it will wipe us out. So it's a balance of inflammatory and anti-inflammatory regulators that are ineffective. So always there has to be balance. So if these things get out of kilter and they become unbalanced, then we're in trouble and it can lead to sepsis. So an overreaction from the body's immune system leads to sepsis. As sepsis progresses, the body starts to lose balance with pro-inflammatory response, helps promote the body's response to fight infection, and anti-inflammatory response. The body loses the ability to maintain homeostasis and it runs off the rails. Results from an infection, which may be, as we mentioned earlier, bacterial, fungal or viral, cells' energy production elevates to facilitate fighting infection. Therefore, we generate a temperature. Increased cellular need for fuel and oxygen to produce energy and remove waste products. So the cells need more fuel and more oxygen to generate more energy to fight infection. When they're fighting infection, the cell's metabolic rate increases and it produces a lot of heat, which is the reason why we generate a temperature. Physiological changes, so the heart rate elevates to facilitate perfusion within the cells. So the cells are demanding more fuel and oxygen, heart kicks up to run more blood carrying fuel and oxygen around the body. Breathing rates elevate to take more oxygen into the body's cells and expel carbon dioxide from waste products. Again, if the metabolic rate rises in the cell's inherent need for oxygen goes through the roof, so our respiratory rate actually increases as well. Sugars are released to help fight infection. So we need fuel for the fire in every cell. So cells need fuel, so fuel is released. So stores of glycogen, stores from our fat. We burn a lot of energy when we're running an infection. Okay, we need a lot of fuel. Temperatures initially climb, but may become low as sepsis progresses and the body starts to shut down. So again, you have this indicator for sepsis of body temperatures above 38.3 or below 36. We can be generating tons of heat and fighting the infection, and we may start to lose the fight, and as the body cells start to die and the body starts to shut down, our temperature will start to drop. White cells increase in the blood, and white cells are the cells that fight infection. So blood results will show elevated leukocytes, elevated white cells, and this is indicative of a serious infection. So sources of infection for sepsis. So, common infective entry points into the body: the skin, cellulitis, abscesses, wounds, the brain, meningitis, encephalitis, respiratory tract, sinusitis, tonsillitis, pharyngitis, upper and lower respiratory tract infections, infective endo and pericarditis in the heart, the abdomen, peritonitis from perforation, bowel ischemia, lots and lots of nasty little bugs get into your digestive tract and can cause issue too. Urogenital polyphrenitis, orchiditis, pelvis. So pregnancy related, we have bones. Septic arthritis is a big one actually, particularly in the elderly, and there's lots of other stuff. So sepsis itself is a potentially fatal response. So what we initially see is this SIRS, systemic inflammatory response syndrome. So this is as the body ramps up. It's initially ramping itself up to fight infection. So if 2 or more SIRS markers are present with evidence of an infection, then the patient is septic until proven otherwise. So what are the markers for systemic inflammatory response? So signs of SIRS. So a temperature less than 36 or greater than 38.3. A heart rate of greater than 90 in an adult. A respiratory rate of greater than 20 in an adult. Acutely confused because our central nervous system is not being perfused correctly and we have apps starting to go offline. Glucose levels of greater than 7.7 in a non-diabetic patient. Why would that be? Because the body is dumping all of its sugar stores to help the cells fight infection. Okay, so this patient may not have eaten in a couple of days and yet their sugars are up because they've dumped all their available sugars to help fight the infection. Has the patient 2 or more of these? If they do, they're SIRS positive in the presence of an infection or suspected infection, and that means that they're septic until proven otherwise. So any 2 of these, temperature less than 36 or greater than 38.3 in an adult, heart rate greater than 90, respiratory rate greater than 20, acutely confused, glucose levels greater than 7.7 in a non-diabetic patient who possibly hasn't eaten, any 2 of those and they're septic until proven otherwise. Shock. So the immune system promotes an over-inflammatory response. Progresses of sepsis to septic shock. Systemic blood vessel dilation to promote blood flow. So all of the blood vessels will start to dilate. Why? They start to dilate because so here's a cell bed. It's got an infection on the go. And what we've got here is we have our capillaries that are delivering blood to these particular cells. What do they need to fight infection? Well, they need fuel, they need oxygen, and they need to remove carbon dioxide and the waste products from cellular respiration. They all need huge amounts of fuel and oxygen because there's an infection in the area which needs to be killed. So here's your infection in the area, and it's in some of these cells. So, what are we going to drop on site here? The blood vessels themselves are going to take your red blood cells, which are RBCs. We're going to deliver your white blood cells, which will fight the infection. These are carried within the blood itself, and they will migrate out from the actual blood vessels and into the cells to help fight the infection. So we have lots of fuel and lots of oxygen. That's fine. We only want these things in the area where the infection is. We don't want them around the whole building. So if this is an area that's in your arm, we don't want them down in your legs as well. What happens is these blood vessels will dilate, and they will dilate to promote here's your blood vessel. And what your blood vessel will do is your blood vessel will go from this state here to this state here. What this facilitates is red blood cells and white blood cells escaping from the blood vessel itself and out into the area where the cells are actually being attacked by the pathogens. So this is what's kind of going on. So, systemic blood vessels dilate to promote blood flow. This facilitates the migration of white cells and the likes of oxygen out to the actual cells themselves in the extracellular space. Blood volume is reduced. So if we have a lot of migration from a lot of blood vessels around the body at the same time, what happens is we have a loss of volume in the blood vessels themselves, which drops blood pressure. Hypotension and hypoperfusion are created. Heart rates may slow, reducing blood flow and inducing critical hypoperfusion. So end organ impairment can fail, so skin becomes pale, cold, clammy, or warm and hot. The brain will get confusion, agitation, and a loss of consciousness. The lungs, we've got an increased work of breathing. We can have nausea and vomiting. Our kidneys can reduce urinary output, which build up toxins in the blood. Our liver can have abnormal function, and again we'll have a buildup of toxicity in the blood. And we got hypotension, so distributive shock around the whole body. As blood vessels dilate to facilitate white cells getting to infected cells, we get low blood pressure. Septic shock or hypoperfusion. Hypotension and clotting in the small capillaries induce hypoperfusion. Hypoperfusion of tissues affect the ability of organs to survive. We then have a situation where multiple organ dysfunction syndrome kicks up, leading to organ shutdown. Multiple organ shutdown leads to the collapse of body systems and patient death. Here's a little video to have a look at how do white cells actually get out of the blood vessel itself, and this shows you.
Extravasation of neutrophils. White blood cells circulate in the blood, searching for pathogens within our bodies. Neutrophils, the most abundant type Extravasation begins when chemokines are released by immune cells at a site of injury or inflammation, activating the endothelial cells of nearby capillaries to express adhesion molecules. Neutrophils respond to the adhesion molecules by expressing counter-receptors, which produce a weak interaction between the neutrophil and endothelial wall. The neutrophil adheres slightly to the vessel wall, rolling along the surface. This movement is possible through unique molecular interactions between neutrophils and the endothelial cells. The neutrophils are slowed down by the formation of weak transient bonds between sinucleus X, a carbohydrate expressed by neutrophils, and selectins, adhesion molecules produced by endothelial cells. The force of blood flow causes neutrophils to roll along the endothelium, causing new interactions to form while old ones break. Eventually, tight binding occurs when integrins known as LFA1 on the neutrophils undergo a conformational change, causing them to bind firmly with endothelial adhesion molecules called ICAM1. With the neutrophil firmly adhered, diapedesis, the process of neutrophils exiting between endothelial cells, can begin. Once outside the blood vessel, the neutrophil migrates to the infection, guided by chemical signals.
Okay, so you can see kind of visually there how white cells actually escape out of the blood vessels and into the areas of extracellular space where the actual infection is. So patients who are at risk of sepsis themselves, so the elderly, the very young, the immunocompromised, comorbidities, all the same things you're hearing about COVID. So, you know, people who are dying of COVID are dying probably of sepsis with these microclots, and they're getting all the same symptoms, and it's really a sepsis response. Antipsychotic medications like clozapine, they create an immune response. So they reduce an immune response. So there is certain patients that are more at risk of sepsis than others. Sepsis itself with signs of shock. So if they have signs of shock and you suspect sepsis, with poor perfusion, it becomes septic shock. SIRS positive patients are septic until proven otherwise. So even if they only have 2 signs of SIRS, so that's your temperature below 36 or above 38.3. In adults, you have tachycardia above 90, tachypnea or fast breathing rates above 20, or sugars in a non-diabetic patient above 7.7. With signs of infection, they're septic until proven otherwise. So we're going to talk about septic shock and how it actually kills people. There's a small little video on this, and I'd like you to have a look at that.
As critically ill patients fight infectious insults, there is often an excessive response that results in the syndrome of severe sepsis. Clinically, you may see increases in temperature, heart rate, respiratory rate, and abnormalities of white blood cell count or differential. As the disease progresses, blood pressure may drop with organ hypoperfusion, and organ systems such as the respiratory, cardiovascular, hepatic, central nervous, and renal system may fail. Traditionally, this excessive response has been associated with the disruption of homeostasis through an uncontrolled cascade of inflammation, coagulation, and impaired fibrinolysis. Deeper examination shows that the microcirculation is the key focus of sepsis injury. The sepsis cascade begins with the activation of the capillary endothelium in response to an infectious agent or toxin. This endothelial damage exacerbates the inflammatory process, resulting in neutrophil activation and expression of adhesion molecules. Neutrophils begin to roll in the capillary and adhere to the endothelium. The increased endothelial permeability leads to a loss of vascular integrity and consequent microvascular leakage. In the lungs, this interstitial and alveolar edema leads to acute lung injury and acute respiratory distress syndrome. Concomitantly, coagulopathy and impaired fibrinolysis prevent red blood cells from delivering oxygen to the organs, resulting in inadequate perfusion and global tissue hypoxia. The amplification of the coagulation pathway results in large amounts of thrombin formation, which converts fibrinogen to fibrin. Fibrin threads with activated platelets form a clump at the site of endothelial activation. Reduced arterial vascular tone, diminished venous return, and the release of myocardial depressant factors lead to hypotension. This is a scan of the capillary circulation in a normal patient. Note the rapid blood flow and numerous capillary loops. Now you see a patient in septic shock despite restoration of normal hemodynamic parameters through treatment with fluids and vasopressors. Note the poor blood flow and capillary loops with intermittent or occluded flow. The depressed myocardial function, widespread tissue ischemia, and multiple organ dysfunction often lead to patient death.
So, again, the visual just shows you the difference in the ability to actually perfuse after the sepsis cascade has gone kind of into hyperdrive. It creates almost miniature infarctions in the microcirculation around the body, and because it actually blocks up circulation, within the capillaries, it means the cells don't get fed, and this is in every organ in the body, leading to death. Here's the actual 2017 sepsis CPG. There's a little bit going on, there's a lot of stuff in the middle of it here, and here's the current one. Again, it seems to be a lot cleaner. There's a few more information boxes, but it's a really easy algorithm to follow. I'd like you to have a look at it. So initially, the patient is generally unwell. We're looking at their heart rate, their respiratory rate, their ECG, their SpO2, and their BP. And what we're looking for there is those kind of SIRS signs, which are pretty easy to spot. Abnormal physiology or source of infection, yes. So if they have, issues with, low SpO2, high heart rates, high temperatures, if they're SIRS positive, then they're septic until proven otherwise. Signs of hypoperfusion, no. Monitor clinical condition, take them to the ED. If there is signs of hypoperfusion, we request ALS. They'll give some fluids and a few other bits and bobs, but it should not delay transport of an EMT ambulance to the emergency department. Have a look at the actual algorithm itself, guys. It's pretty easy to follow. So some changes in it. So CPG clinical condition entry changed from patient unwell to patient generally unwell with suspected infection. So what we're doing is we're leaning here towards, an infected patient who may be heading for sepsis, is to wake us up really. Mandatory sequence steps, abnormal physiology, source of infection added. So patient generally unwell with suspected infection. Again, we have some other mandatory boxes popped in there. At-risk decision process pathway added. Evidence of at-risk instruction information box added. And a SIRS sequence steps has been removed, which is interesting. Okay, so high consequence of infectious disease instruction information box added. Signs of shock, poor perfusion, instruction information box removed. Risk stratifier instruction information box removed. History of penicillin allergy instruction information box removed. So there's a lot of stuff taken away, which makes the process algorithm very easy to follow. Again, pediatric sepsis, there's a couple of little changes. It's a standalone CPG for sepsis and peds. Difference to the adult sepsis CPG. SIRS criteria is not stipulated at all. There's a sepsis red and a sepsis amber flag, which we need to have a nosy at here. So there's sepsis red flag, talks about altered mental status, inappropriate tachycardia. Remember, pediatrics they definitely tend to do a lot better than adults. They tend to compensate far longer than adults. So you need to be a little bit more kind of switched on to, You know, are they struggling? Are they working hard? Sometimes they make it look easy. Non-blanching rashes in there, prolonged central capillary refill, hypotension or clinical deterioration. Any of these things in children are red flags. Sepsis amber flags, inappropriate tachypnea, so fast breathing, altered functional status, practitioner concern, parental concern. You know, we don't want to we want to err on the side of caution with kiddies. That's really what it's about. So there's the algorithm for kiddies. It's pretty clear. It's pretty easy to follow, particularly for our EMTs. There isn't an awful lot of nasty trapdoors in it. Have a good read through it. We're going to do a couple of scenarios here on the day when we're practicing this anyway. So be mindful of clinical signs in children, as their ability to compensate, as I've mentioned, is far greater than adults. When they show evidence of hypoperfusion, practitioners should be clinically mindful for the potential for sepsis. If children are showing signs of hypoperfusion, if they're hitting more than 2 aspects of the pediatric assessment triangle, the resuscitation department needs to be on standby, because they will compensate for so long and then they will literally fall straight off a cliff. Use the pediatric assessment triangle to signpost early clinical evidence of hypoperfusion. The PAT is my go-to with peds. And if they ding more than 2, if they ding 1, they're sick. If they ding 2 aspects of the 3 aspects of the triangle, then they need to go to resus. So we'll have a chat about that in the pediatric lesson. So the summary: infection may lead to sepsis. Undiagnosed sepsis may progress to septic shock and patient mortality. Sepsis is not difficult to suspect. Using the search criteria for adults, it's really not difficult at all. Suspected sepsis must pre-alert the ED. There's a huge mortality. So mortality rates at 33% at 30 days. So this is Barrodal 2020. Some of the evidence in Ireland here will show mortality rates with septic shock of greater than 50%. It's pretty easy to spot. It's not something that we should be missing. So thanks for that, guys.